CT description, we have this classical description on CT of perilymphatic distribution of these nodules. And these nodules are described as micronodules, 2 to 5 millimeters in size. They follow the bronchovascular bundles. They are seen along the interlobular septa, interlobar fissures, and subpleural regions. And it's a predominantly upper lung involvement. So involves the upper and mid zones of the lung. And I'll show you what these nodules are. So as you can see a lot of small nodules there. Okay, I believe these would come as subpleural. Okay, definitely near to the pleura. These ones seen along the bronchovascular bundle would be peribronchovascular or peribronchovascular, what we would call. Here you can see the fissure, and you can see some irregularity of the fissure, and along with that nodule. So these are the perifissural nodules, along with the more discrete nodules, which will be the interlobular nodules. Again, one more example, and you can see, okay, not just the nodules, but you can also see the interlobular septal thickening. Okay, that's one there. There's one here. And this is a peribronchovascular area, which is irregular, thickened, and along with that, you got these nodules. These are your subpleural nodules there. And these are the ones along the fissure, which is quite irregular. And you can see the nodularity quite well there. Okay. So I hope you can see, this is a classical description of sarcoidosis. But here's the catch. Not every patient presents this in this manner, which is why sarcoidosis is not always a clear-cut diagnosis. Many times it's a diagnosis by exclusion, and I'll tell you why as we go ahead. Here again, you got a diagrammatic representation of, these are your peribronchovascular nodules on the extreme left. These are along the fissure. Okay, the one in between the interlobular septa is interlobular ones. Okay, then these are along the margins of the interlobular septa, and these are perifissural ones there, and this thickening of the interlobular septa there. The other two are MIP images, which again show this condition quite well, nodules all over, but you can see a pattern to these nodules. So now you'll have a good idea of what's the characteristic CT features of sarcoidosis. A few other signs have also been mentioned. One of them is the galaxy sign. Now, what is the galaxy sign? It's a large nodule or a focus of consolidation with irregular boundaries, and it's thought to represent coalescent of much smaller nodules into a much bigger nodule mass or focus of consolidation, which I'll show you. So this is what's your galaxy sign. I think it's something looks like an big thing there, and these margins, these satellite nodules, which are at the periphery, gives you your sort of irregular or almost speculated margin sort of picture. That's your galaxy sign, characteristically described in sarcoidosis. You can see some subpleural nodularity there. You can see some interlobular septal thickening there also. Okay, so this sort of irregular margins, which really is due to satellite nodules, and then a big area of coalescent smaller nodules which have got together to form something like a mass or an area of consolidation, is your galaxy sign. The other sign is similar, but here the nodules are still, they're near to each other, but they've not coalesced. So this is your cluster sign. So here you got, as compared to the sarcoid, here they're not really confluent. It's just smaller nodules which will all come near to each other. Okay, it's not characteristic for sarcoid, as we will see. A lot of the signs, in fact, a lot of the signs are not just characteristic for one, but it is characteristic for granulomatous diseases, which is what sarcoidosis is an example of. So here you have your cluster sign. So here you can see nodules, almost a ground glass pattern, but if you enlarge the images, you'll see that you have these small nodules which all seem to be very close to each other. And that's your cluster of nodules, or your cluster sign in sarcoidosis. Reverse halo, not characteristically told for sarcoidosis, but it's been described in sarcoidosis also. Reverse halo was first described in organizing pneumonia. But of course, now we know it's been seen in other conditions also. So in reverse halo, as compared to your halo, okay, where you get a surrounding ground glass, here in reverse halo, you got the ground glass or the nodular densities in the center, surrounded by a more consolidation sort of image. I'll show you. Okay, this is the specific description of reverse halo. So central ground glass opacity surrounded by denser consolidation or tricentric shape, which should form, it may not be a complete rim, okay, but it should form at least 3/4 of a circle, and it should be at least 2 millimeters in thickness. So this is your Fleischner Society guidelines for a reverse halo sign. It's not unique to sarcoid, we said. It's seen in other conditions, infections. So if you can think of tuberculosis, which is a granulomatous infection, it is seen. Also seen in fungal infections, CAP, but more interestingly, it's even been described in COVID pneumonitis. Also seen in other conditions which are non-infective, like infarctions, okay, your granulomatosis with polyangiitis, previously called vaginous, sarcoidosis, as we are describing now, lipoid pneumonitis, and also some pulmonary neoplasms, because it looks mass-like, isn't it? So this is your reverse halo sign. In halo sign, the ground glass is towards the periphery. Here, the ground glass part is towards the center. And if you look carefully, along with the ground glass are these punctate small nodular densities, which are your sarcoid nodules. And there is not so much seen in the other ones, but here you can see the rim of consolidation quite well. Okay, so that's your reverse halo sign, also described in sarcoidosis. As I said, those are your characteristic signs or classical findings. We've gone through those. Now we'll go through your atypical radiological findings, which makes diagnosis of sarcoidosis more challenging, and which is why we call it the great masquerader. So some of the atypical findings of sarcoidosis cause confusion with conditions like bronchiolitis, lymphangitis carcinomatosis, hypersensitivity pneumonitis. Again, reverse halo can be seen in hypersensitivity pneumonitis, Langerhans cell histiocytosis, even conditions like lung fibrosis like UIP or NSIP pattern. And of course, we already said organizing pneumonia is one of the differentials. So coming to airway involvement, again, we would expect, you can get these nodules like elsewhere. You can get them within the small airways, either peribronchial or even intraluminal. And this can cause granulomas or fibrosis, which can present as airway disease. And airway disease we classically describe as areas of air trapping. Okay, and that's what gives your mosaic attenuation. It's been described as extremely common in sarcoidosis, but it's common in other conditions also. And of course, as we said, it's a finding in airway disease. So you can here in these CTs, you can see there are these areas of ground glass opacities and interspersed normal lung, which gives your mosaic attenuation. More linear densities are also seen. Okay, and you can see areas of, I can describe that as traction bronchitis. So some sort of traction going on the underlying bronchioles there. Okay, in this level we would say bronchioles, and some of the bronchioles appear a bit irregular, almost a bit dilated there. Here too. Again, an example of mosaic attenuation, okay, in a case of sarcoid with airway involvement.